Okay, Kelly, menopause boot camp. Let's get stuck into this. So,
Let's do it.
exactly, what is perimenopause and menopause?
Yeah, that's a really good question, Tanya, and one we get all the time. I mean, up until a few years ago, nobody had even heard of perimenopause, let alone thought that they were actually in it. So the definitions are a little bit blurry, and perimenopause isn't really an official medical term. It's sprung up from this term, which means around the time of menopause. So what's menopause itself? Menopause itself is where you run out of eggs. Literally, your ovaries run out of eggs. So it's a moment in time when you've ovulated your last egg. And we don't actually know when that is at the time. All we know in retrospect is a year later when you suddenly go, oh, hang on a minute, I haven't had a period for 12 months. So that's kind of the definition when you haven't had an ovulation for 12 months, which is usually based on the observation that you haven't had a period for 12 months. Now, as you can imagine, there's lots of problems with that definition. Can you pop up the slides, the first couple of slides for me, please, Tanya? Okay, so in medical circles, this is the really confusing looking diagram that tells us the different stages of menopause. And the definitions are all based on where you can see that red arrow, the final menstrual period. So that's the popping out of the last egg, the last period that you have. And so the stages are of menopause, whether it's before or after menopause, are all kind of referenced from that. But the problem is, what if you aren't having any periods? What if you've got a Mirena? What if you've had a hysterectomy? What if you've had an endometrial ablation or something like that? So in practice, it's not very helpful, and I find it very, very confusing. But in medical terms, this classification, they talk about the fact that in early menopause that you'll start to see some subtle changes in the length of your cycle and things like that. And then as you get later along, you'll notice that there are bigger gaps between the periods, and that the periods might be getting heavier. And then you sort of get up to the point where you have your final menstrual period. And then beyond that, everything beyond that is considered postmenopausal. So essentially, that's what this complicated picture represents. And I find that functionally that's really difficult to kind of get your head around and to explain to patients. Can you show us the next slide though? So I find this is a much more helpful way of thinking about it, that the perimenopause is all of that time leading up to your actual last ovulation, and that menopause is officially diagnosed when it's been 12 months since that last ovulation. And as I said, we may or may not know when that actually was. And then postmenopause is any time thereafter. So does that kind of help?
It does. And I've got a really interesting question about that. So I've got a friend who she thought she'd gone through menopause, hadn't had her period for I think it was about 18 months, and then she got a bleed.
Mm.
So what's happening there? Is that something else, or is that just our body really confused?
Look, that's a really good question, because the definition of let's assume that she wasn't on any hormonal contraception or hormonal treatments or anything that was stopping her periods. So if she naturally went for 12 months without a period or 18 months without a period, then that is classified officially as menopausal, and it's even reinforced if they're around the normal menopausal age, which is 51 on average. So technically, if that woman's had a bleed 18 months later, that's what we call a postmenopausal bleed. And it's really, really important that you go and talk to your GP and possibly gynecologist about that, because if you are menopausal, you're not supposed to be having any bleeds thereafter. Occasionally people do. Occasionally people have a rogue ovulation, or they've sort of assumed that they'd stopped ovulating, and then they have one or two more kind of down the track. But for the vast majority of people, once you've gone that 12 months, you shouldn't really bleed thereafter. And postmenopausal bleeding, the problem with that is it may signal some changes to the lining of the uterus, which is called the endometrium, which might be particularly a problem, like polyps or even precancerous changes.
Okay, so definitely anything that's unusual getting it checked out.
Yeah, absolutely. I mean, even though we're expecting to see changes to your cycle and changes to the way you're bleeding in the lead up to menopause, if there is really dramatic changes from normal or really super heavy bleeds or, anything, that sort of sits outside the normal range, I will still be doing investigations just to check that the lining of the uterus looks normal. And occasionally there'll be a referral there to a gynecologist so they can do a procedure, usually a hysteroscopy D&C. That's where they stick a camera in through the cervix and have a look around in the uterus, and they can do a biopsy of the lining of the uterus to make absolutely sure that there's no precancerous changes going on.
And so why is it so important for us to sort of understand if we are in menopause or if we're in that sort of lead up phase?
Yeah, that's a really good question too. A lot of my patients are really hung up on, am I menopausal? Am I not menopausal? How do I know? And my answer to that a lot of the time is, do you really need to know? What difference is it going to make to your life or how we treat you? Because the problem is there's often a lot of uncertainty in the diagnosis. And as you've just pointed out, even if we think we've got the diagnosis, there might still be bleeds and things going on. And that will look very, very different for women who are on hormonal treatments versus not as well. So the bottom line is do we need to know? Now, if it's a case of for women who aren't sure if they've finished ovulating and it's important for contraceptive purposes, for example, then absolutely we need to know, and we're going to be chasing a diagnosis. So the classic example is if I've got a woman who's got a Mirena in and her Mirena is sort of technically expired, it's been 5 years, I think it's extended these days, it might even be 7 years. But, we want to know, is it safe to get it out? Because we don't know if the Mirena's stopped the bleeding or if she's stopped bleeding because she's not having, any ovulations. So in that case, that's one of the rare cases where it might be useful to do some blood tests to actually try and officially diagnose menopause. But, earlier than that, particularly in perimenopause, blood tests are worse than helpful because they can be misleading. There are such dramatic changes in your hormone levels from day to day and week to week that it might lead you to think falsely that you're not menopausal or that you are menopausal, and that can be even more of a problem.
Yes, and I can imagine, given that you can get pregnant during perimenopause, that could be really, really catastrophic for some people.
The classic oops baby.
And so tell us a bit about the symptoms, like what are some of the examples of what we might experience, what we might see, and I guess also how common are they?
Yeah, absolutely. Can you pop up some of the slides that I have there, and that this will help to explain it somewhat? Well, first of all, it needs to be said with these poor ladies here, I'm sure a lot of us have seen, memes and things that look a bit like this with the sort of classic caricatures of the menopausal woman and, making a joke of it. And that can really undermine the reality of the experience for a lot of women because, really significant symptoms are no joke at all. I think that we've been the butt of society's jokes for long enough on this one. So let's move on. Okay, so as to how common symptoms are, they're really, really common. So about 80% of women are going to experience symptoms as they go through the menopausal transition. And of those, about 20% are going to be experiencing quite severe symptoms that can be really debilitating. So, as you can see, the vast majority of women are going to be experiencing symptoms. It's more the norm than not. So this slide here just gives you a bit of an idea of the scope of the symptoms. So the classic type of symptoms that people are going to report are things like hot flushes and night sweats. That's the one that everyone sort of has always known about. But it's actually a late sign, and it's not actually as common as people think. Again, about 80% of women are going to experience hot flushes, but only 20% are going to find that those are, so bad as to cause dysfunction and problems. And it can be a really late sign. So you can be getting lots of symptoms during perimenopause before you really start to get flushes as you approach menopause. Then people complain about muscle and joint pains. They complain about mood very, very commonly. That's one of the biggies and one of the more early subtle signs that people can start to have. It's a bit like the frog in a pot, isn't it? It's like, the pressure builds, your symptoms kind of gradually get worse and worse and worse, and you can think of lots of reasons why you might be feeling crabby, so the penny doesn't really drop as to what's going on. But in perimenopause, when you're starting to sort of have worsening cyclical symptoms, if you're noticing that your mood, your depression, even migraines and things like that as you approach your period are getting worse, then that can be a subtle sign that it's actually hormonally based. The headaches, as I just mentioned, we do really commonly see that, particularly for women who've always had migraines or migraines that were hormonally responsive, that those cyclical migraines really start to get much worse in perimenopause. The good news with that is that a lot of them get much better postmenopausally. Cognitive changes. So this, again, super, super common. Women will explain it as brain fog a lot of the time, that just sort of blunting of cognition, feeling a bit woolly-headed, not being able to form sentences, which might happen to me during this presentation, so apologies for that. Memory, just doing wacky things and feeling like, is this early dementia? Am I going crazy? Am I going to be able to cope with my job? These are the sorts of things that really undermine women's confidence, particularly in the workplace and how they present socially. Then you've got a range of urogenital type issues, which are, again, really, really common, although these ones tend to gradually get worse over time. So unlike some of the other symptoms like mood things, which tend to get better postmenopausally, things like vaginal dryness, discomfort with intercourse, sort of abrasions and things with sex, urinary frequency or leakage, gradually over time, the effects of having low estrogen will impact that area of the body more and more. So those sort of problems need to be gotten onto quickly, and they do require treatment or they're just going to get worse. And then, as I mentioned, sexual function, which doesn't just involve vaginal dryness or pain with intercourse. There's a lot of very, very commonly, in fact, people will report low libido, low desire, inability to orgasm, can't get aroused very easily as well. And this is just incredibly common. The presentations that I've done in this area, it's actually the norm to have low desire after menopause. So I think that we need to be prepared for the fact that we're not going to have the sort of spontaneous rushes of desire that we've had in our youth. But that doesn't mean your sex life is over or that it can't be great. It's just a matter of bringing awareness to that and going, so what do I need to do now to optimize the opportunities in that area?
And definitely a good reason to come along to your workshop.
Yes, exactly. Nice link forward there. I saw what you did.
That's what I do.
Yeah. Now, do we have another slide here on symptoms? Right. So this slide here is a really good demonstration of the basis of the difference in symptoms that you get at the different stages of the menopausal transition. So as you can see, when we're in our reproductive years, that premenopausal time, the hormonal changes that are happening are very, very rhythmic, like breathing in, breathing out, kind of pulsatile. Our bodies are well adapted to that, like the changing of the tides. But then very early on in perimenopause, things start to shift a little bit. You get a change in that ratio of estrogen relative to progesterone. Perhaps even though you're still ovulating regularly, you may be having plumb regular periods like normal, but maybe your ovaries aren't producing quite as much progesterone after you ovulate every month, and that balance is shifting a bit. And so you're starting to notice, my PMS is getting a little bit worse every month here, or my periods are getting heavier, or my migraines are getting worse. And then we move on a little bit further through perimenopause, and you start to actually go, I'm getting bigger gaps between my periods or smaller gaps between my periods. And then you might actually miss periods or start to notice that, your periods become quite erratic or very infrequent. And that is signaling late perimenopause. So that, the more erratic they are and the less frequent they are, that's generally signaling that you're starting to run out of eggs and your ovaries are going to sputter to a stop quite soon.
So with mine, Kelly, I found that my periods, they still were quite regular, but they became a lot lighter. And that was
Mm,
after I had my children. It sort of never went back to what it normally
mm.
was.
There is a very, very big spectrum here, and this is why it's so fascinating to me is the different experiences that women have. Very rarely I'll have someone who'll come along and go, nope, my periods just stopped. They were normal, 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 and then stopped, like that's it. And that was their experience. They never had a symptom, but that is really, really uncommon. So, okay, let's get to the line between the perimenopause and the postmenopause here, which is the point where you've had your last ovulation. And then as you can see, there's sort of flat line when it comes to estrogen and progesterone, because if you're not ovulating, you're not producing any progesterone, and the baseline production of estrogen from the ovaries is much, much lower when you're no longer ovulating. So that explains why you get that much more level playing field when it comes to hormonal instability that might impact your brain chemistry and cause mood or sleep disturbance or whatever. So that things postmenopausally, women do report actually being calmer and happier in general and, not so moody. The thing is, though, as you can see, that pervasively low estrogen, that's where we start to get things like the impact over time on the vulvovaginal tissues with gradual thinning and drying of the vaginal tissues, regression of the labia, sort of issues with sexual dysfunction and things and urinary frequency and leakage. So that's why, that sort of environment is over the longer term causing those problems.
Now, I have a question with this.
Mm.
What is this follicle stimulating hormone and this luteinizing hormone? What are they and what do they do?
Yeah. So this has to do with the brain ovarian axis, let's say. So in your pituitary, you've got an area that produces hormones that send signals to your reproductive organs. So follicle stimulating hormone, its job, as it says, it's like what's written on the tin, it is to produce follicles. So it sends down follicle stimulating hormones, which travels to the ovary to stimulate the production of follicles to flog your ovaries to ovulate. Now, as you can imagine, if you're starting to ovulate less frequently because you're running out of eggs, that's sending signals up to the brain, and the brain's going, I better send more follicle stimulating hormone to try and make more follicles here. So gradually, it skyrockets, goes really high. So that's why a high FSH, a high follicle stimulating hormone level, is associated with menopause. But as I said before, in perimenopause and around the time of menopause, it can be a bit misleading because it can be up and down all over the place. When you're postmenopausal, it's going to be consistently high. So the only way we can be sure of that is repeated testing of the blood tests. Luteinizing hormone is something that happens during the reproductive years. In the mid-cycle, you get a surge of luteinizing hormone, which is actually a trigger for ovulation. So, you don't really need that for that purpose anymore postmenopausally.
Okay, so we've got menopause, it's our period stopping, there's symptoms that happen.
Mm.
And I know you've mentioned some of the problems in terms of our vulva and our vagina and all those sorts of things, but what other thing, like, is there other stuff to it that we need to be thinking about in terms of like our health and stuff?
Yeah. So this was really interesting to me. When I started WellFemme, it was because women had symptoms and they couldn't find doctors who were knowledgeable about menopausal hormone therapies to be able to help them manage them. And so early on, it was all about managing the symptoms. And that's great. We can do that now. People can make a booking by telehealth and we can talk to them about their symptoms and start them on menopausal hormone therapy. And they come back to me and they go, I feel so much better. I'm sleeping better. I've got more energy. And I go, great. And how are you going with those lifestyle changes that we talked about? How are you going with you wanted to get more exercise and be more strict about your sleeping and, make better choices in your diet. Oh, yeah. I'm going to get to that, but my work's really busy, or my kid's doing year 12 at the moment, or I've got to put dad in a nursing home or whatever, and so yep, I'm going to get to that. So what I realised was that where we were falling down was that failure to recognise that not only are we getting symptoms at this time that need managing, but what's going on in our bodies that is being signalled by those symptoms that are going to be a real long-term problem for us down track. So it's not as simple as just, treating the symptoms. What we need to be mindful of is this low estrogen and low progesterone and, all the changes that we're experiencing, they have impact on every system in your body. They're going to have huge impact to the development of heart disease, diabetes, dementia, osteoporosis, not just vaginal dryness and stuff that I mentioned earlier. So if you pop up that slide, Tanya, we'll zoom through, some of the longer term implications of the hormone changes after menopause. So as I mentioned before, bone loss. So let's put it this way. You're kind of gradually, your bones might peak, say, in your 20s or 30s, and then they're gradually sort of getting lower and lower over time as we go. But what happens at menopause when you have that really dramatic drop in estrogen is an acceleration of bone loss for a short time. So in the 5 years after menopause, you could be losing 10 to 15% of your bone density. It really accelerates for a short time, and then it sort of levels out. But it's still declining. So you've got to really understand that that's a trigger for dramatic bone loss at that time, and that if we are going to prevent osteoporosis, that is the time when we need to take hold of that. First, we need to be aware of it, maybe doing a screening bone density scan, and maybe if you've got a family history or a diet that's low in calcium or other risk factors, because there are many, then, that might be a time to take hold of that and go, right, we need to take other interventions here, certain types of exercise or increasing the calcium in our diet, taking menopausal hormone therapy, which is, it's actually indicated as a treatment for osteoporosis. So it's very effective at helping arrest that bone loss. So yeah, bone loss, really, really important. And let me tell you something really scary, that for women who are over the age of 50 who experience a really dramatic, bad fracture of the hip, about a quarter of those will be dead within 12 months.
Wow.
Yeah, so that's a scary statistic, isn't it? It has a lot, obviously, to do with the underlying condition that caused that person to fall and fracture in the first place, frailty or, poor balance or whatever that led to that in the first place, but very scary to think about.
And it's interesting because, that is something where your hormone replacement therapy has been used for quite a while, because I know my mum, she had a bone density scan when she was before 50 and was put on estrogen to sort of help with that. And I don't think she had progesterone, which I think is why she then had to have a hysterectomy a few years later. But it's interesting how that has been something that has, I guess, been in place for a while. So when sometimes our doctors might be a bit resistant about HRT or MHT, but it has been used for a long time and proven, I imagine.
Absolutely. There is a lot of data to support this. And that, as I say, there are only 2 medical indications, TGA approved indications for the use of estrogen therapy. One is debilitating hot flushes and the other is osteoporosis. So it's well proven.
There you go.
So heart disease. Now, there are the 2 big killers of women in Australia are dementia and cardiovascular disease, not breast cancer. Breast cancer is like number 5 or 6 on the list. Breast cancer these days is very, very, commonly survivable, 95% survival or whatever. But, what's going to get you is most likely dementia or cardiovascular disease. So heart disease, incredibly common, and what happens with the decline in estrogen is a rise in inflammation in your body, and this leads to plaques being laid down in your arteries, which can calcify, which can cause, heart attacks, strokes, all that sort of stuff. So obviously super important around midlife and around the onset of menopause that we really take stock of what our risk factors for heart disease and cardiovascular disease are and go really doubling down on, controlling those risk factors. Similarly, type 2 diabetes is a bit tied in with that. Being on MHT, for example, really dramatically reduces your risk of developing diabetes, and not getting diabetes really dramatically reduces your risk of developing cardiovascular disease. So, these metabolic diseases, which are all having an inflammatory basis, are very intimately tied in with that drop in estrogen, because estrogen itself is anti-inflammatory. Obesity. So we know that a drop in estrogen levels leads to more of a central weight gain. So around the middle, around the organs. So it leads to that apple shape as opposed to, the earlier pear shape that women tend to have. And that in itself is also a risk factor for heart disease. Also cognitive decline, early dementia, and what's not written there is mental health symptoms as well. So all of these things are increased in risk around menopause. We're seeing bigger increases in diagnosis of ADHD and neurodiversity around perimenopause. It's all tied in with that instability that I demonstrated on that earlier slide, which really impacts your brain chemistry. If your sleep is bad as well, if your sleep's being disturbed by hot flushes, it's going to just exacerbate all this other stuff as well. So yeah, that's a quick Cook's tour of a lot of the things which are long-term health problems associated with the decline in estrogen, particularly that happens around menopause.
Okay, so I guess the big question now is, what can we do about it? Like, okay, it's not a doom or gloom summit. We need to be thinking about what are the positive things that we can do that will actually help manage this.
Yeah, that's a really good question, Tanya. So when we're talking about how to manage not only the symptoms, but also our developing risk of chronic diseases, you can't just start with the medication. Menopause itself is incredibly holistic. The type of symptoms that you get are multifactorial and coming from everything that's going on in your life and your past life experiences. And so it is with this. We've got to consider the whole holistic picture, the multifactorial picture. So first and foremost, we need to be looking at the lifestyle stuff that's contributing here. So whatever your symptom is, your primary symptom, we need to take a step back and go, well, okay, my mood problems that I'm having, what's contributing to that? Have I had mood problems in the past? Have I got situations going on in my life at the moment that are contributing to that? Are there short-term contributors to that? Am I overworking and neglecting my sleep and recreation? Am I not getting enough exercise? Am I drinking too much caffeine and alcohol? So all of these things, every symptom you can name needs to have a lifestyle approach first and foremost. Look at all of the contributors to whatever that symptom is. So we've already touched on the psychological symptoms. When it comes to vaginal symptoms, there's a huge range of things that we can do there. So, for example, if you've got vaginal dryness, there's a huge range of vaginal daily moisturizers that you can use out there. So if it's just a matter of feeling uncomfortable wearing jeans or riding a bike, you can use these sort of really good vaginal moisturizers like Silk or Replens, things you can buy over the counter. There are fantastic lubricants to be used for intimate activities. And just on that, I would always recommend for any kind of rubbing or intimate activities down there, whether you're with a partner or just by yourself, using lubricants is really, really important because the tissues do become quite fragile. And for that sort of activity, I would avoid water-based lubricants and go more for either silicone or oil-based lubricants. And the oil-based ones are the ones you should go for if you're using any toys that have silicone coatings or anything like that. There are some really great products out there. I like this one, Olive and Bee, which you can buy online. It's an emulsification of olive oil and beeswax, so it's not as runny as using just, say, coconut oil or olive oil or something like that. And I also say to people, if you've got tissues that are a bit itchy or irritable or easily dried out, make sure you're using something like the Olive and Bee or even a zinc-based, nappy rash cream or something externally on those tissues if you're going to be sitting in a soapy bath or going swimming in a pool full of chemicals or something like that. So any kind of risk of exposure to chemicals and irritants, you want to be protecting that area against that too. So that's a little side thing there, but these are examples of some of the sorts of treatments that you can use to manage those symptoms.
I imagine with that, what we're washing ourselves with, making sure we're not using things that are heavily perfumed and all that
Mm.
sort of thing would actually be a factor as well.
Oh, totally, totally. The number of people that I speak to that actually have never been told not to use soap on their genitals is quite astonishing. Like when I say to them, "You're not washing in soap or using perfumed cleansing products or something, are you?" And they go, "Oh yeah, what else am I supposed to wash it with?" I'm going, you don't, it's a self-cleansing kind of a system. What you've got to understand about your vagina is that it's colonized with its own little microbiome that keeps itself in delicate balance. And if you're using soaps and things down there, you're changing the pH completely. You're stripping the protective oils away from the delicate tissues. So they've got no means of defense. And that's why they're subject to irritants and itching and things like that. So it's really important. Just washing with water, just in the shower. A lot of people have those handheld shower heads where you can really kind of get in there and wash, but you will need to get in amongst it with your hands and give yourself a good wash with water. If you have to use something, I would recommend something like sorbeline, just a gentle unperfumed sorbeline or Cetaphil or something like that. That's just a really gentle kind of moisturizing base wash. But another thing that's really important too is, as I showed you on that diagram, where postmenopausally and the estrogen is pervasively low, and gradually over time this causes thinning and fragility of those vulvovaginal tissues. Vaginal estrogen is hugely powerful at helping reverse that. And in Australia at the moment, there's a lot of pharmacies that are involved with a trial that you can even get vaginal estrogens over the counter, I believe. But if not, it's something you can get from your GP with a prescription in any case. And just using it every day for a couple of weeks, directly applied to the lower vagina and the tissues externally, which you would need a cream to do, that really, really quickly improves the resilience and the tone and the lubrication of the vaginal tissues. And then you just drop it back to using maybe twice a week or something for maintenance after that. And it is very, very low risk to use. There is hardly any systemic absorption of estrogen. So even if you're somebody who's had breast cancer or something, or has been told that you can't use MHT, it's usually safe to use vaginal estrogens, and it makes an enormous difference to quality of life and sexual function for so many women. So do make sure that you're not neglecting that, or go and talk to a doctor who's knowledgeable about it if you're suffering in silence. So urinary symptoms, likewise, a lot of women complain of increasing urinary frequency. That's super, super common. And it does seem to be tied to a certain extent in the lower estrogen levels as well, because a lot of women who will go on MHT will report actually that their urinary frequency has improved. Also, if you're having problems with leakage or urgency, sometimes you'll find that the use of vaginal estrogens even can make a difference to that. But it's inconsistent from person to person, and actually the evidence we have around that is inconsistent. One thing I would say that is hugely powerful at helping with urinary problems is a pelvic floor physiotherapist. These are God's gift to women. I kid you not. If you've got urinary problems and you've never spoken to a pelvic floor physio, now is the time for sure. And these are physiotherapists that are specially skilled in helping women with pelvic floor issues and urinary issues. And they can take the time to do a really thorough history of, like, what sort of urinary problems are you having? Are you leaking when you cough and sneeze, or are you just kind of all of a sudden being hit with the urge when you put the key in the door when you get home and all of a sudden have to go to the toilet, or you'll lose the lot, that kind of urgency? So is it an overactive bladder, or is it like a physical stress leakage because you've got incompetency of the valve that's letting the wee come out, that sort of thing. So they're really good at honing in on that and offering a range of different things. So for example, they might get you to do a bladder diary where you're keeping a record of, liquids in, liquids out, the timings that all of that happens. When do you wee most? What things are you having in your diet that might be irritating it? And then they can give you, say, bladder training to help you to dampen down the urgency signals from your brain that are causing your bladder to contract prematurely. So, they might get you to go through little exercises where you gradually stretch out the time between going to the toilet so that you can really desensitize yourself for that urge to go to the toilet. They'll do a really good physical examination in most cases if you've got like pain or leakage or whatever, they'll probably do an examination where they put fingers in your vagina to have a really good feel around, to have a good look for a prolapse and stuff like that. And they are very good at identifying conditions that might be improved by use of, say, a physical pessary, which is a device that gets inserted into the vagina and helps to support the vault of the vagina and the front and the urethra itself. That's the wee tube, so that you can function better, so you don't have like a prolapse that's almost coming outside of you, or that you have a functional bladder that can actually control the wee coming out. And they might say to you, you should go along and see your GP and get some vaginal estrogens, which I talked about before.
Yeah.
So yes, please, if you've got bad urinary symptoms, please go and see a pelvic floor physio. They are amazing.
And by happy coincidence, we do have Courtney later this week.
I know, right?
And in the following 2 weeks in our actual workshop series, yes, Courtney is an exercise physiologist with expertise in pelvic floor, so we'll definitely be talking about that as a hot topic.
Yeah.
Now, the other thing I wanted to ask about this is, for those of us who, like, some of us have had babies like naturally, some of us have had babies through the sunroof, which is not mine, or we might not have had children at all. Does any of that make a difference? Because I know we used to talk about, we damage our pelvic floor if we have babies and stuff like that.
Look, yes and no. Even women who've had nothing but cesareans can have prolapses and urinary issues and problems with their pelvic floor. So it doesn't mean that if you haven't had a vaginal delivery that that's not going to be an issue for you. And there are lots and lots of different types of surgeries that women will have. For example, a hysterectomy, which might interfere with the ligaments that support the vault of the vagina and all that stuff down below. So even though you don't have a uterus anymore, it doesn't mean that you won't necessarily have a prolapse or things that are causing problems down there. So certainly women who've had children have had a strain on their pelvic floor that women who haven't had children haven't actually gone through. But there are other things that impact, everything from genetics that affect the collagen of the pelvic floor and the structures of the pelvic floor, to, your weight and the type of activities you do. If you're a weightlifter, for example, and you're putting lots of pressure on your pelvic floor, that's going to make a big difference. So again, like all these other symptoms, very, very multifactorial. So let's talk about sleep for a moment. And, I'll mention later on about the women's wellness program that we run. But one whole module is devoted to energy, which particularly has a focus on sleep, because, that again is one of the more common problems that women will experience. A lot of these women will have had lifelong sleep problems that become even worse at menopause and perimenopause, but also a lot of people will find that they're having sleep problems for the first time around the menopausal transition. And again, hugely multifactorial. What is going on in your life that's contributing to this? Do you have really poor sleep hygiene habits? This is where the lifestyle stuff comes in. Are you staying on TVs and screens up until you go to bed at night? Are you drinking coffee or caffeine all hours of the day? Do you have bad habits that are contributing to this, drinking too much alcohol in the evenings? Are you going to bed with a busy brain thinking about work? Are you feeling stressed? Do you have medical conditions like pain or depression or something that's not being well managed? So we've got to, again, look at the holistic nature, and what is the problem? Is it trouble going to sleep? Is it trouble staying asleep? Is it that you've got sleep apnea and you're being woken up because you're starved of oxygen? So a systematic approach to sort of getting the history out there and identifying and diagnosing particular sleep problems is really, really important. But of course, first and foremost, if you are waking up bathed in sweat 5 times a night because you're having dreadful flushes or sweats, and this is related to your hormones, you might find that your sleep problems aren't going to get solved until you manage those flushes. Periods, I mentioned earlier on that periods can get much heavier, and this is usually tied in with, again, those subtle shifts in production of estrogen versus progesterone. So because your progesterone is very, very low if you're not ovulating very often, progesterone's job in this whole picture, and going back to basics, we've got the estrogen and the progesterone in your reproductive cycle. The estrogen's job is to thicken up the lining of the uterus so that, a fertilized egg can plop into it and make a baby. And the job of the progesterone, which comes along after ovulation, is to stabilize the lining of the uterus and keep it stable for long enough for that to happen. But if it doesn't happen and all those hormones die away, then your lining sheds and you have a period. So progesterone, in the role of combined hormonal treatment, its job is to balance out the estrogen, so it thins and stabilizes the lining of the uterus. Now, if in perimenopause you're actually getting periods or you're getting stretches of time where you're not producing very much progesterone, or you've got a general decline in your progesterone levels, this is impacting on your periods. It's making them heavier because there's nothing to check the estrogen that's being produced every month, or lower levels of progesterone not keeping it in check. So that's one of the reasons why periods will be heavier. Also, skipping periods, like having a cycle where you haven't ovulated, so there's no signals for the lining to shed, and so you might go on for much longer than you normally would, which means further thickening of the lining of the uterus. And when you do get a period, it's a bloody doozy. It's huge. You're flooding all over the place. So this is why so many women have dreadful flooding periods throughout their perimenopausal years. And that's absolutely not okay. And there's absolutely tons of things that can be done about that, everything from medications to procedures to Mirena IUDs or different types of pills. And you absolutely need to go along and talk to your GP. If they don't feel competent to manage it, they can send you along to a gynecologist who is, but your GP should at least be checking your iron levels to make sure that you're not becoming anemic. But if you're bleeding all the time, I can pretty much guarantee you are, and maybe you need to start an iron supplement.
So I did read somewhere that if you have low iron, you're more likely to have heavier periods. Is that?
Oh, I would have thought the other way around, bit chicken and egg there.
Okay.
Yeah. I mean, most women know if they're having really heavy periods, but maybe they're not associating the fact that they're exhausted all the time and lacking in energy, or getting breathless climbing a flight of stairs, that's where the anemia comes in. Yeah. So sexual issues, really, this is a big can of worms, and one that we'll address more in the workshop that's coming up next week. So what I would say about that is, think again of the multifactorial nature, think again of the holistic nature. There is this tendency now, because there's lots of influencers and doctors on social media talking about testosterone. Women will go, oh, that must be the reason why I've got a crappy libido. I'll just go and get some testosterone and everything will be okay. Think again. That's not going to be the magic bullet for you unless you've got what's called a hyposexuality disorder, where you literally can't become aroused and orgasm. Then testosterone is not going to be a quick fix for you. When women are talking about low libido, the most common I see is that they come along saying, I just don't feel like doing it. I just can't be bothered. It takes so long for me to become aroused. He wants it more than I do. I just would rather read a good book or get some more sleep or whatever. And what we're talking about there is spontaneous desire, and that is absolutely normal, super common. It's what Dr. Rosie King used to refer to as the hump of reluctance. That it's like there's all of these other factors that are barriers to you actually getting started in the first place. But once you can breach that hump of reluctance and actually get warmed up and get engaged with your partner, you're off and running, and you can actually become aroused and actually enjoy yourself. So if that's more of your problem than actual being able to kind of be responsive sexually, that's more of a psychosocial context kind of thing. And so we've got to look at all pieces of this puzzle. When are you trying to have sex? Is it at the end of really busy, stressful days when he taps you on the shoulder and you just go, oh God, I can't be bothered, or is it that you actually don't have a great relationship at all, or you don't have a partner right now? What is getting in the way here? Are you overthinking? Are you not excited? Are you just bored by it? we need to look at all of the reasons that are contributing here. So I say to my patients, and we'll talk about this more next week, but maybe you need to actually create spaces, actually do some scheduling of sex where you create space at times where you know you're less likely to be tired and distracted and no kids around or whatever it is, and just go and program some fun things to do with your partner, not distracted by screens or other activities, and just let yourself have a bit of fun and engage with one another intimately and just see where that goes. So yes, look, sexual issues, and then there's all the vaginal stuff we talked about before as well that comes into that. And do you have a history of sexual trauma or other sorts of things that are getting in the way? There's so much that comes into this space. But I will mention here in brackets, STI prevention. There's a lot of repartnering that goes on at midlife, and we tend to forget about the fact that we are as prone to STIs as the young people. And in fact, it's people at midlife that have the highest and increasing rates of STIs of all the age groups at the moment, just because we're kind of not as prepared for it as the young people. So when it happens opportunistically, we're not protecting ourselves. We're not ready for it. So finally, the hot flushes thing. We've already talked a lot about this. Again, lifestyle. If you know what your triggers are for hot flushes, like alcohol, spicy foods or whatever, and you're still continuing to use those, then you can expect that you're going to get flushes. So those might be things you can manage to help. If you're sleeping well, then and you're well rested, you're less likely to get flushes. But then again, if you're getting flushes, you're less likely to sleep well. So again, that's a chicken and egg kind of thing. There are lots and lots of different kinds of treatments available, both hormonal and non-hormonal, and we can talk a little bit about those if you would like. But examples of non-hormonal treatments include antidepressants. Some of those are very, very powerful and can reduce hot flushes by up to 50%, and that can be a real boon for people who also need an antidepressant for mood symptoms or other things. There are anti-epileptic medications which are really powerful at reducing hot flushes, such as gabapentin and clonidine. There's a drug called oxybutynin, which is great for reducing urinary frequency and also happens to be good at reducing hot flushes as well. And there is a new drug called fezolinetant, or Veoza is its trade name, that's become available in Australia this year. That's only very new. We don't have a lot of long-term experience with it, but it seems at the moment that it's another good viable option that people can try if they don't want to use hormonal treatments for their flushes. I will say a word here though about complementary and herbal therapies, which is that we don't have a lot of evidence that they're even effective, and the problem is that we don't also have a lot of evidence that they're safe. So the thing is, when you go to a doctor and they prescribe you a medication, you've got to understand that that's been through a very rigorous testing process before it gets approved by Australia's Therapeutic Goods Association. So you really want to be looking at the things that have been rigorously tested. And not only do we know that they're effective, but also that they're low risk in terms of safety, or if there are risks associated, we actually know what those are. And this is the problem. When you get things compounded, when you're getting herbs and things like that, we just don't have that evidence. We don't know what the long-term effects are. And with compounded products, they can vary enormously in the quality of the products, the dose delivery, the way that they're put together by different compounding pharmacies. So I would definitely think again about those and just stick to things that are TGA approved.
And I know for me, one of the big triggers I had with hot flushes was if I had eaten garlic during the day,
Okay.
whether it was like roast garlic on its own or whether it was in something, I could tell you anything I ate that had garlic in it based on whether I had hot flushes that night. And I actually, I know it was so annoying because I love garlic.
So typically women will have a FODMAP reaction to that, and they'll know by how often they go to the toilet afterwards.
Well, I found I took myself off garlic, like that sounds like a medication when I say it. But I stopped having garlic in anything. I made sure it was everything I made was garlic free, and I did that for a few months, and then I slowly tried some, and it's been fine now. It's like my body just needed a bit of a detox of garlic. Maybe I'd been having way too much. I don't know. But it's interesting how, as you say, that lifestyle things of what we do, what we're doing to our bodies, what we put in our bodies, all has an impact on all these different things as well. Okay, so the big question, menopause hormonal therapy, MHT or HRT as we might have known it in the past. What is it? When should we use it? When should we use it? All that sort of stuff.
Yeah. Look, that's the $1 million question. There is a lot of controversy around MHT, and that, because of that history where there was that big study done around the year 2000 that scared the heck out of everyone and made them stop MHT. And now in reevaluating all that data, we realized that it was presented very poorly, and actually we threw the baby out with the bathwater. What that meant was that a lot of women who would have benefited a lot and had a lot of prevention of heart disease and things like that ended up really suffering unnecessarily because of that. But it's controversial, and doctors were unsure. And now there's a lot of attention on menopause. So women are demanding answers, and doctors are getting really stressed about that. So there's a lot of debate, a lot of controversy. But, there is a lot of clarity here as well. The bottom line is, if you look at the statements by the world's major menopause societies, there is a lot of consistency there, which is that for most women in the menopausal transition, if they start menopausal hormone therapy at around the menopausal age, that it is really low risk and very beneficial in a lot of ways. So, there are a few exceptions to that. Like, for example, generally, you're not going to be offered menopausal hormone therapy if you've got a history of breast cancer, particularly an estrogen receptor positive breast cancer or other cancers that are hormone sensitive. There might be other relative contraindications. For example, if you've currently got undiagnosed weird bleeding or uncontrolled high blood pressure or those kinds of things, that's got to get sorted out before you can start menopausal hormone therapy. But the bottom line is that when it comes to hot flushes, at least, there is absolutely nothing that is going to be as effective at treating menopausal hot flushes as giving you some estrogen, because low estrogen or fluctuating estrogen is the reason why you're getting those hot flushes. So if we can level that out, if we can supplement that, that's going to be the most effective thing. It's not the only thing. As I mentioned earlier, there are lots of non-hormonal things, but what they don't tell you is the long-term health benefits of being on estrogen. So all those things I said to you earlier about the rise in, different risks and things like that happens, if we start menopausal hormone therapy, estrogen therapy particularly, at around the onset of menopause, what we're doing is, instead of seeing that big decline in estrogen, we're supplementing that. We're bringing it back up, and we're helping to reduce the risk of those things happening. So we're helping to, prevent or alleviate that big drop in bone density and the rise in heart disease risk and the rise in dementia risk and all of those other things. So there are known long-term health benefits. And so if you start menopausal hormone therapy at around the normal age of menopause, so it's kind of like, as far as your body's concerned, you're not menopausal, you're getting the benefit of your body kind of having those supportive hormones for longer. So to explain it in a really simplistic way, if you were on estrogen therapy, say, for 10 years between the age of 50 and 60, and then you stop, that 10 years, it's kind of like, in a certain way, your body is 10 years younger. Certain systems in your body are 10 years younger, and that benefit moves with you for the rest of your life. You've got that what we call legacy effect of having that 10 years of hormonal protection for life. The important thing to remember here for women who are going through an early or premature menopause is that the opposite is true. If you go through a menopause, be it because you've had your ovaries removed or gone through chemotherapy or whatever it is, you've gone through 10 years before you should have, then you're at a disadvantage by 10 years. So it's like your body was being prematurely aged by that losing loss of estrogen 10 years too soon. So it's super important for those women to get really, really good advice from health professionals and make sure that they get supplementation of estrogen up to the normal age of menopause if they can.
And so for women who do go through this, so I've
Mm.
obviously spoken to lots of women,
Mm.
but for some of them, they're advised that, okay, you take the hormone therapy up until the, the average age or the normal age and then
Yeah.
come off it.
Mm.
Why would we be doing that?
Mm.
Is there a reason why we should do that? Or is that just like an old belief that we need to sort of investigate?
You mean the coming off part?
Yeah.
Yeah. Look, absolutely. I guess the question is why are you taking it? Now, if you're taking it for symptom relief and the symptoms come back when you stop, then don't stop. If your quality of life is better and there is no contraindications to you being on it, not only are you going to get your symptoms alleviated, but you're going to get long-term health benefits from being on it. So why would you stop? There is a subset of women, though, who don't really have bad symptoms, but know that it's likely it's having long-term health benefits for them. And they say, you know what, I don't want to come off it. I want to stay on it. And if there's no contraindications or strong reasons why they need to come off it, then I'm supportive of that. Now, again, going back to the position statements of the major menopause societies internationally, very few of them will recommend yet using menopausal hormone therapy for primary prevention, that is for prevention of chronic disease alone in women who are otherwise healthy. But we know that this is true. We know that there are long-term health benefits from being on it, and a lot of women just make that choice anyway, that they don't want to come off it, and I'm okay with that. But the main thing is, are you doing all the things that keep it being safe for you? So, let's talk about breast cancer, for example. Now, the older types of menopausal hormone therapy, and we're talking about combined menopausal hormone therapy, right? So this is women who have a uterus, they have to have the estrogen and they have to have a progestogen to stop the lining of the uterus getting really thickened up. In the olden days, when that big study was produced, there were an older form of progestins, synthetic progestins, that were shown after 5 years of use to slightly increase breast cancer risk. Now, when I say slight, it's about the same as if you were drinking 2 glasses of wine per day. It's certainly much lower risk than being 20 kilos overweight or lots of other things that we do in our lifestyle. And, for some women, if they are getting exponential improvement to their quality of life, then it's really neither here nor there to them, that small increase in risk. So they continue to use it anyway. But the modern products that we use, like body identical micronized progesterone, has not been shown to have that same increase in breast cancer risk. So we will, certainly my team at WellFemme, we will always be erring towards those safer, more modern products, the body identical hormones. And this is not, we're not talking bioidentical compounded stuff here, folks. We're talking body identical molecules that are, the same sort of in structure as what your body naturally produces, but they are TGA approved medical products. So the thing about that is that now that we have these more modern products, I say to my patients, okay, you're worried about breast cancer. That's a very, very valid concern, because 1 in 7 of us on a population basis will develop breast cancer. I have had breast cancer myself. So 1 in 7 of us are going to get breast cancer, regardless of being on MHT. That risk still exists. You might get a stroke. You might have a heart attack. You might get it. There's a background risk to every woman in society, a certain background risk of these things. And we can't promise you that that's not going to happen. But what we know from the evidence is that these modern products don't substantially increase your risk of breast cancer. So what is more important to note is that if you are the 1 in 7, which you might be, and you start to develop an early breast cancer, early detection is the important thing. Because if it's a hormone sensitive cancer and you continue to take MHT, you could be accelerating that cancer. So early detection, you need to be doing your, breast self-examinations every month or 2. Notify your GP if you've noticed any new changes. Make sure you're getting regular mammograms. And if you're somebody who's at increased risk for genetic or other reasons, then you might even need to talk to, a genetic counsellor or a doctor, your doctor, about getting a heightened kind of screening program. So that's my approach. That's my approach to breast cancer advice, really.
While we're on the topic of breasts,
Mm,
I do have a question, and it's
mm,
not necessarily MHT related, although I am taking it.
mm.
Why have my boobs become so heavy and so sensitive?
Maybe you're on too much estrogen or not enough progesterone. That could be the case. I mean, we would have. I never know from person to person what's
Hmm.
causing what until we try a few things, try a few adjustments, and see what happens. But estrogen tends to be, having too much estrogen tends to be the thing that gives people sore boobs. But it could be something else.
Yeah.
We just have to try a few things. Mm-hmm.
Yeah. And I think that's it. Like, we're all different, and it's all about having the conversations with someone who
Mm.
can have those conversations in an informed way.
Absolutely. Yeah. But estrogen, it does stimulate breast tissue and it does stimulate the lining of the uterus. And that is why, we need to be monitoring these things. We need to make sure it's well balanced by progesterone if you've got it, if you've got a uterus, or if you've had bad endometriosis, even if you've had a hysterectomy. If you've had bad endometriosis, you still might need progesterone because there might be endometriotic deposits still in your pelvis even after a hysterectomy. These are all the nuances which make this kind of work so fascinating. Mm.
Cool. Okay.
Mm.
So, are there potential benefits of
Mm.
MHT?
Yes, look, as I mentioned before, there's the improved bone density. There's, there are actually decreased risks of certain cancers for women who are starting at around that age of menopause, like a decrease in colorectal cancers or endometrial cancers. Obviously, decrease in fracture risk because you've maintained your bones better with the MHT. We know that if you start early, within 5 to 10 years of your menopause, that there's going to be protective effects on your cardiovascular system. The jury's still out a bit. There's mixed messaging around dementia prevention, but I think lifestyle is way more powerful when it comes to dementia prevention, particularly vigorous exercise. Doing vigorous exercise has been shown to reduce the risks of certain types of dementia by up to 40%.
Oh, wow.
So, yeah, I know, like, lifestyle is the most powerful thing. The MHT is great. You're going to get symptom relief, and we know that there's some bonus benefits to your long-term health. But, the stuff that really, really matters here, Tanya, is the lifestyle stuff. Understanding what's happening in your body at this point so that you can take that evading action early. Yeah. And look, overall, like, whatever else is going on, if you're using MHT and you're finding that you're getting great symptom relief and better quality of life, that's going to enable you to be functioning better to address all of those other things, right? All the other lifestyle factors.
Okay. So,
Mm.
final things.
Mm.
What are your main take-home messages, particularly around the whole menopause transition?
Okay. I was anticipating this question and I have prepared a slide. If you would mind putting my slide up. Firstly, information. Be well informed. The problem is, the thing that's gotten us all in the past is just, lack of awareness. Nobody talked about it. We didn't know what we didn't know, but now we do know what we don't know. And now we've got means of going out there and finding out. So make sure you're well informed. I'll show you some resources in a moment of where you can get good information from. But, things like the Australasian Menopause Society or the International Menopause Societies, those are really, really important sources of information. The thing I want to stress here is getting individualized medical advice when it comes to your symptoms, your particular medical situation, and lifestyle risk factors and all of those things. We see a lot of people who come along with very vested, agendas based on what they've been told in a Facebook group. And they want what that lady's having. I'll have what she's having, because they think that it's going to do for them what it did for her. But that's not necessarily true. Everybody is so different that, the effects might be completely different in somebody else. So the individual advice is really important. And I would say, go along with a baseline understanding of information, but go along with an open mind. Be prepared for them to, impart their information to you and offer you options to consider. But equally, if you feel like you're being gaslit or that you're hearing things that are very, very different to your understanding and Googling or whatever, do be prepared to advocate for yourself, ask questions, or go and get a second opinion if necessary. But my main point, and I hope I've brought that home, is the most powerful things that you can be doing for your health and well-being have nothing to do with medication. They have everything to do with just recognizing and understanding what this time of life means to your body, your mind, your brain, your well-being, and looking really hard at where you can make those kind of lifestyle improvements now. Because you think about it, one small thing like 5 minutes of skipping a day or something that you might do now. Imagine what that adds up to over the next 20 or 30 years in terms of your bone and heart health and brain health. Like one tiny little thing that you can do. So we just need to identify where the bang for buck is going to be. And I have a few suggestions about that if you want to go into my next round of slides, Tanya.
Ta-da!
Okay. Ta-da. Well, first of all, a little plug here for WellFemme. So for anyone out there who's going, oh my God, why don't I know this? Or my GP, fobbed me off about that, or I just don't know where to go for help. You can book in with one of our WellFemme doctors and get a full menopause assessment where, we can give you that individualized advice. So do feel free to hop on the website. Next slide, please, Tanya. The other thing we have is loads and loads of sources of information. So we've got blog posts, we've got webinars with similar content to this, on a whole full range of subjects. So you can go onto the website and get some really good information. It's all free. We've also got an online menopause assessment tool, which you can kind of use to sort of just gauge what your symptoms and situation might mean for you, and what range of different types of treatments might be suitable for you.
And you also have resources for GPs if there are medical practitioners out there who would like to know a bit more and make sure that they actually have all the information.
Absolutely. We even have a couple of webinars on the site for GPs, and we have a whole suite of things planned to help support GPs in the coming year. So we really welcome, contact by GPs who would like extra information and support. And even if they're having some tricky patients that they need some help in managing. On that subject of chronic disease prevention and what we need to know, it's something I identified really early on, that my patients just don't understand. Now that they're feeling better with their symptoms, they think that's the end of the story. And so I really, really wanted a mechanism for being able to bring home the importance of these changes at life. So that's why we've developed the Next Phase Women's Wellness Program. I got together with 3 of my other buddies. One is a dietitian, one is an exercise physiologist, and one is a mindset coach. And we cover off on that full range of topics that you can see there on the screen. We do a full-on systems review of what's going on in your mind, body, brain, right through the whole of the different body systems in the menopausal transition, so we can help each individual woman recognise where her bang for buck is going to be. And we also have online community. We have personal coach and small group coaching sessions that we offer through the program as well. So, it's a full start to finish. We even send you out a beautiful workbook in the mail that you can use as a kind of journal as you work through all this stuff. So, yeah, absolutely. So I really would welcome anybody who's thinking, I really need to know more about this stuff. We'd really welcome you in the Next Phase program to come along and work with us. And the community is fabulous. We're getting such lovely women in there. And by the way, have a look at that gorgeous Insta site that my assistant Ivy came up with. So you've got to go on our Instagram site just to check out the beautiful Insta site that Ivy's created with all of the videos and links and everything in the background. It's just stunning.
I love it. Okay. Anything else before we wrap up this session? I mean, obviously we're going to see you again next week for those of us who are joining us for the workshops.
So a lot of the resources I've just discussed, women can use this QR code. So it's on screen now if you want to scan it, and it takes you to a landing page that's got information about all of these things. I would point to the fact that in the swag bag, you've got a sneaky little discount code that you can use if you'd like to join the next phase program. And I think what I will do also, Tanya, is I've got a little cheat sheet about MHT, a simple guide to menopausal hormone therapy, which I'll put as a freebie in the swag bag as well.
Sounds perfect. Awesome.
Mm-hmm.
Well, thank you so much today, Kelly. That's been really great. And I'm like going, okay.
We've covered a lot of territory.
It's been huge and a really great start, because we're now all thinking, and we're all thinking, okay, well, what are the next few days going to bring? And oh my gosh, I've really got to get serious about this midlife and menopause thing. It's not just for people who are experiencing severe symptoms, it's for everyone who's going through this.
Absolutely. I'm so excited for this summit, Tanya. Congratulations on bringing it all together, and I can't wait to see what the other presenters are bringing in the next few days.
Okay, Kelly, why are you excited to be part of the Navigating the Change online summit?
Oh, I am so excited for this summit. I'm excited to hear what the other contributors will bring. One of the things that I'll be talking about in our session is the holistic nature of menopause and what all the contributing things in a woman's life are to the symptoms. And, you know, the breadth of stuff that's coming to this summit is really indicative of that. So, you know, people who will be talking about, you know, prolapses and pelvic floor, psychological aspects, menopause in the workplace. Like, there's so much going on. So I just love the holistic nature of the whole summit, and I can't wait to be a part of it.